topic tonight is diagnosis and treatment of pediatric epilepsy, and our guest speaker is Aimee Luat, who is a pediatric epileptologist at Children's Hospital of Michigan, and she'll be joining us shortly. Before we get into that, let's talk a little bit about what some of your experiences are with the process of diagnosis and some of the decisions that had to be made along the line in terms of treatment. Does anyone want to share some experiences that you've had with that process of the diagnosis of epilepsy and selecting a treatment plan, and some of the concerns that you may have or experiences that you've had, or some questions that you are hoping will be answered through this call?
I can share something. Russ, this is Dawn.
Okay.
And my son was diagnosed when he was 3. He's now 6.
Okay.
He had a seizure at home. Both my husband and I were with him, and we didn't know what the heck was going on. We ended up at Children's Hospital, and they suggested we do an MRI and an EEG, which we did. And before we got the results of that, he had a second seizure. Mm-hmm. At that point, we still didn't know it was epilepsy. Right. But we ended up back at Children's Hospital, and that's when they gave us the diagnosis, and they set us up with taking trileptal.
Okay.
So he was on trileptal. A few months later, he had another seizure, and they added Keppra. Mm-hmm. And months after that, he had 2 small seizures. They increased the dosage of the Keppra and the trileptal, and he has been seizure-free for 2 years. It was 2 years in November.
Oh, congratulations.
We did yes, that's wonderful news. We had an EEG, another overnight EEG, but Dr. Siraji found the results showing that he still has the same brain activity that would indicate he is still susceptible to seizures. So we are another year of waiting, still taking medicine, still no seizures, and then again in November we'll do another overnight EEG to see what's going on. What I did learn was that you could do an EEG of my brain, of my husband's brain, and it could be the exact same results as my son.
Yeah.
But we haven't had a seizure, so we don't have epilepsy. It's not producing a seizure, but for him it is.
Yeah.
So in November, if we still have the same results, Dr. Siraji says that we'll just start taking him off the meds to see if he's done. So there really isn't going to be, yes, he's grown out of it. It's going to be, well, he hasn't had any, so maybe he's done,
Right.
So we'll wait and see.
There is no single test you can take to say, yep, you're cured, or yep, it's over. So that is what you described there is a lot of what we'll be discussing tonight about, do you treat seizures? Do you treat the EEG? How do you make the decision about whether or not to wean off medications? So we'll be discussing all of that in a lot more depth tonight. So thanks for sharing.
We're very lucky. Thank you. He's responded well to the medicine. He hasn't had any trouble, any side effects. So it's just a waiting game. I look forward to the information tonight. Thanks, Russ.
Well, excuse me, Russ.
Yeah.
I know I have something to say on that, because when I was younger, and I started seizing, I was 2. When I was about 14 years old, my seizures stopped for a couple of years. I know my mother thought my seizures were gone. They came, I started having seizures again.
Yeah, thanks, Clinton. Yeah, that is a good point, is that, sometimes your seizures can go away, you think you've outgrown them, and then they can return later in life. Sometimes that happens when there are hormonal changes. Some people may have their seizures go away in early childhood, but then they come back in puberty, or they come back later in life during menopause or other transitional periods. Or sometimes another injury or illness can make them return again. So it is not it's a very complex condition, and it's hard to predict what to expect. So thanks, Clinton, for sharing that. Who just joined us?
Hi, this is Dr. Luat.
Hi, glad you made it home safely.
Thank you. Sorry I'm late.
Oh, no problem. We had a couple people share some things, and I think a nice lead into what we're going to discuss today. So, again, I would like to welcome Dr. Luat, who's a pediatric epileptologist at Children's Hospital of Michigan. So can you give us a brief overview of your clinical and research interests, and then also your experience with this particular topic?
Okay. First of all, I would like to thank you, Russ, for inviting me to this conference call, and it's a great opportunity for me. So I'm a pediatric neurologist and epileptologist. I trained at Children's Hospital of Michigan and Wayne State University in Detroit. So I did a pediatric neurology residency there, and I also did my neurology and epilepsy fellowship in the same institution. And I am a board-certified pediatric neurologist and epileptologist, and my research interests are pediatric epilepsy and also tuberous sclerosis complex, or TSC, which is a genetic condition associated with epilepsy.
Okay. Great. All right, so let's start talking a little more about the topic, diagnosis and treatment of pediatric epilepsy. In an ideal world, what should happen after a child's first unprovoked seizure, and then how does that differ from what actually happens in some cases? Can you talk a little bit more about that?
Sure. First, let us define seizure. I know most of you know what seizure means. It is an event that is caused by excessive firing of the brain neurons. And when you say unprovoked, that means the seizure or a cluster of seizure occurred because in the absence of any precipitating factors like fever. So typically, it is one of the scary experience for every parent to see, especially a convulsive event. And usually what usually happens is after a convulsive event, the child is taken to the emergency department, and the ER physician assesses the child. Of course, when the patient comes to the ER, the child has to be stabilized, make sure that he's breathing okay, and his seizure has stopped. If it is necessary to give a IV seizure medication to stop the seizure, if the seizure has been going on for more than 3 minutes, ER physician will also do that. So after stabilization of the child, basically the ER physician will take the history, examine the child, and depending upon their judgment, they might need to do a CT scan, blood work. Usually most of these children return to their baseline, and ideally an EEG should be done, but it may be done within 24 to 72 hours following the onset of seizure. Most of these patients return to their baseline, so what happens is these children will be discharged home and will be advised to see their primary care physician, and subsequently the primary care physician will be contacting the neurologist to get the patient seen sooner. So typically, like in Children's Hospital of Michigan, we always try to accommodate these children who have new onset convulsive seizure. We see the patients. Once the neurologist see the patient, we also order an EEG, which is a brainwave test. And usually we also order for brain MRI, which is the type of imaging of the brain that will help us figure out what could have caused the seizure. Typically for new onset seizure, blood work is not routinely recommended unless there are signs of dehydration or vomiting. Spinal tap, we don't typically do that unless there is a question whether there's a meningitis or encephalitis. Okay. And toxic screen, ER physician may consider that in cases wherein cases of toxic ingestion is suspected. But again, if there is infection and if there is toxin in juice, these are no longer considered as unprovoked seizure. They are provoked seizures.
Okay. And then what are some examples or common scenarios where early diagnostic and treatment decisions aren't properly handled, and what are the potential consequences in those cases?
You mean if early diagnosis was not properly handled?
Yeah.
Yeah, I mean, because, not all episodes that are shaking are seizures. So it's important to really be clear with the diagnosis. An example is if a teenager was thought to have an epileptic seizure, but actually the episode was non-epileptic. There is a condition called non-epileptic events, and in teenagers we have seen cases of psychogenic non-epileptic events, wherein the child also seemed to have seizure, they have body shaking. However, it is not due to abnormal discharges in the brain, and the worst thing, that potential consequences that might happen is if this child is treated with seizure medication, and these episodes, since they are non-epileptic, it will not respond to the seizure medication.
Right. Okay. So what information do the standard diagnostic tools for epilepsy provide, like patient history, MRI, standard EEG, et cetera? What type of information does that provide you, and how does that guide your treatment decisions? And then under what circumstances do you consider using additional diagnostic strategies, things like video EEG monitoring or other neuroimaging studies?
Well, patient's history is very important because it gives us an idea of the character and the sequence of the event, especially if the parent witnessed the episode. So it will help us determine whether the spell is consistent with the diagnosis of epileptic seizures. We physicians specifically look for signs on physical examination of tongue biting. We ask the history whether there is any incontinence or if the child wet himself. We also specifically ask if the parents witness whether the eyes are open or closed during the event, and also whether the seizure happened from sleep or when the child was awake. We also ask for any provoking factors such as fever, presence of history of trauma, and in adults, we also ask for any history of alcohol withdrawal. Once we have figured out that this could be a seizure, we also try to figure out what type of seizure did the patient have. So we ask questions like whether one side of the body was jerking, whether the eyes moved to the left or to the right sides, or whether both sides of the body were shaking. And after the seizure, did the child have any weakness on one side of the body? Because these signs may suggest that the seizure is coming from one area of the brain, therefore suggesting the diagnosis of focal seizure. It is also important to take note of the birth and developmental history as well as family history. The history of any complications during birth can be an important information, as well as the presence of developmental delay and history of previous meningitis or encephalitis, because these are risk factors that may increase the risk of the child to have another episode. On physical examination, we look for signs of abnormal findings like a big head and certain birthmarks, because there are birthmarks that may suggest or may be linked to an underlying neurologic condition, like, for example, with tuberous sclerosis complex, which is a genetic condition associated with epilepsy and developmental delay. If you look at their skin, they have this hypopigmented or white patches, and that may also help us figure out the need to start the medication if necessary because of the risk of having another seizure. And for the testing that we typically recommend, of course, EEG. As I said earlier, routine blood work is not done unless there is a history suggesting dehydration, diarrhea, or vomiting, and toxic screen if there is any suggestion of toxic ingestion. We do brain MRI. This is what we prefer for new onset unprovoked seizure. However, oftentimes MRI cannot be done within as quickly as possible. So if the child who presented with first unprovoked seizure is not returning to his baseline and still have signs of neurologic abnormalities in the ER, we may do a head CT scan, which is on an emergency basis. And I mentioned earlier that we do EEG. We prefer an EEG with sleep deprivation because the yield of this is higher than those EEG without sleep deprivation. We tend to do stat EEG if the child, when you say stat, that means urgent EEG, if the child has not returned to baseline after the first unprovoked seizure. We also do EKG, which is electrocardiogram, if there is a question whether the spell was due to a cardiac or heart etiology.
Right.
You asked the question about when do we use additional diagnostic strategies.
Yeah.
We have also done video EEG monitoring, which means an EEG that is attached to the child. At the same time, there is a camera that is monitoring the child, and we typically do it overnight. Sometimes we do it after 2 or 3 days. We do this test in conditions wherein the diagnosis of seizure is inconclusive. That means we are not sure. Like, for example, episodes of staring or unresponsiveness that we are not sure whether really seizure or secondary to inattention. We also do this if we know that the child has a seizure and we have already put the child on seizure medication and the child continues to have seizures. So we want to further characterize what type of seizure the child is having. And the third purpose of doing this is to determine, this is for children who has intractable epilepsy, which means inability to respond or inability for the seizure to be controlled despite being on 2 or more seizure medication, because it will help us find out if there's a seizure focus that may help us in addressing the treatment for this child. Aside from video EEG, in certain conditions like intractable epilepsy, in addition to MRI, we have done functional neuroimaging modalities like positron emission tomography scan. So basically, this type of scan will show the function of the brain and will help us localize and pinpoint where the seizure may be coming from. Some centers utilize other specific modalities like SPECT and also magnetoencephalography. So it depends upon the epilepsy centers.
Okay. Are those most often used in pre-surgical evaluation as opposed to just
Yes,
diagnosis?
we use that in pre-surgical evaluation. In Children's Hospital of Michigan, our epilepsy center's strength is the use of positron emission tomography scan in combination with diffusion tensor imaging and video EEG.
Okay. And back to one of the standard tools that's used, MRI, what specifically are you looking for, and what types of things, what are the most common abnormal findings that you might find that would support or rule out epilepsy?
Yeah, I mean, we are looking for any abnormalities in the brain structure, particularly in the cortex, because the cortex is this superficial layer of the brain that generates seizures. So there are conditions that may predispose you to having seizures, like, for example, if the child has brain malformation or an old stroke that was acquired at birth. These are conditions that may cause brain lesions that can lead to seizures. And head trauma too, because any history of head trauma, especially those severe traumatic brain injury, may cause gliosis or scarring in the brain, and that can irritate the brain and may lead to generation of seizure activity.
Okay. And roughly speaking, about what percentage of children who turn out to have epilepsy actually initially have a normal MRI and a normal standard EEG?
Usually probably at least 60%, 60 to 70% may have a normal EEG. And even if the child has an underlying epilepsy, they may continue to have abnormal first EEG. That's why we neurologists and epileptologists, we like to repeat the test and also do the video EEG monitoring, because routine EEG is just a 30 minutes recording. On the other hand, overnight recording like video EEG may give us more information. With regards to MRI, many of our patients, seizure, the cause is unknown. So MRI may be normal in most cases, in majority of cases, but with the advent of PET scan and more sophisticated MRI, we are starting to know more of this previously called cryptogenic or unknown causes of epilepsy because of the more sophisticated neuroimaging modalities we have.
Right. Okay. And what you mentioned psychogenic non-epileptic seizures. What are some of the other conditions that need to be ruled out before coming up with a diagnosis of epilepsy? And how often do you see patients who've been misdiagnosed by the time that they get to you?
That's a very good question because, compared to adults, the non-epileptic events, usually the most common one are the psychogenic non-epileptic events. But in children and in infants, the differential diagnosis is broader, and because they have physiologic or normal behavior that may look like seizures. For example, breath-holding spells, wherein the child will have this precipitating factor like being upset or feeling pain, and then afterwards they will stop breathing, and some of them may develop some jerking of the extremities that may look like seizure, but actually the reason for the jerking is because of the loss of oxygen supply in the brain from the breath holding. Other conditions like gastroesophageal reflux, there's a condition called Sandifer syndrome, wherein because of the severe reflux, the child would have stiffening of the back, and they will have this back-arching posture that looks like tonic seizures. So this is one thing that we have to rule out, especially in infants. There are sleep disorders that may look like seizures, like night terrors and nightmares. They may mimic what you call frontal lobe seizures, which typically happens at night, and so that's why we always ask these questions to the family, whether the child have any episodes at night that look like seizures. Migraine headaches or complicated migraines may also mimic seizures, especially if there is an aura. Because, if you have a seizure coming from the back part of the brain, which is the occipital lobe, it will also cause you to have some visual hallucinations. With migraine, you may also have visual auras. So that is one of the differential diagnoses. We see a patient who complains of any abnormalities in their vision that occurs in an intermittent fashion. Movement disorders like dystonia and tics may also mimic seizures. What else? And then we mentioned about the psychogenic non-epileptic events. And I'm sorry, what was your other question?
Just how often you see children who come to you and they've been misdiagnosed.
Quite, yeah, probably around 20%.
Okay.
In adults, the incidence of psychogenic non-epileptic events can be higher. Many of them present to epilepsy centers, and they have been treated with several seizure medication, and they turn out to be non-epileptic. So the prognosis for children who have been diagnosed to have psychogenic non-epileptic events is actually better compared to adults.
Okay.
But the frequency of seeing these psychogenic non-epileptic events in children is less compared to adults.
Right. Okay, so many parents that I talk to can't accurately identify what type of epilepsy their child had. They might be aware of what seizures they have, but they can't necessarily say what type of epilepsy they have. So how often are you able to provide a diagnosis of an epilepsy syndrome, or if a syndrome is not possible to diagnose, can you typically provide some information on localization and cause?
Yeah, we can do that based on the description of the history. However, in my experience for the diagnosis of pediatric epilepsy syndromes like absence epilepsy or Orlandic epilepsy, probably among the patients that I have seen, I have diagnosed roughly 30% of them.
Okay.
Because when you say epilepsy syndrome, that means they have this characteristic seizure type that fits with the typical EEG findings. So for the past 4 years of my practice, 30 to 40%, I was able to give a diagnosis of epilepsy syndrome. And you mentioned about how do we provide information on the localization of or focus of the seizure. Yeah, we can do that through clinical history. Sometimes in those situations that syndromic diagnosis is not possible. Mm-hmm. And we specifically ask for the features of the seizure, and we can determine whether it is focal onset or what we previously called as partial seizure, or generalized, which has always been called generalized, even in the previous International League Against Epilepsy classification.
Right. So you can usually determine whether it's generalized versus focal.
Yes, based on the clinical history and supported by the EEG findings. But take note that in 30% of patients with generalized epilepsy, they may also have focal features. So right. There is this borderline zone that they may show some head turning to one side, but actually they are generalized seizures.
Okay. And why is it important for parents to know as much as they can about the type of epilepsy their child has and not just the type of seizures?
Yeah, it is important because it also helps in the prognosis. You mentioned about the type of epilepsy, and based on the recent revision by the International League Against Epilepsy, we have classified epilepsy not only based on the type, whether they are focal or generalized, we also base them based on the cause of the seizures. So it is important for the parents to know whether the seizure is related to a abnormality in the brain, whether it is related to a genetic abnormality, or whether the cause is currently unknown. Okay. Because, the prognosis, whether the child will outgrow it, is affected by what type of epilepsy the patient has.
Yeah, and as are the treatment options available, I would assume, in some cases.
And the treatment options available too, because we have different seizure medication for partial or focal onset seizure, and we also have different seizure medication for generalized seizure. And if the seizure is difficult to control and it is focal, we always investigate for possibility of surgical modality or surgical treatment.
Okay. So you briefly mentioned the new definition of epilepsy that came out recently from the International League Against Epilepsy. So can you just briefly describe that new definition and what impact, if any, this has on diagnostic and treatment decisions?
Sure. So now the International League Against Epilepsy has recently defined, previously we defined epilepsy as the presence of two unprovoked seizures in two separate occasions. With the recent meeting of the ILA, International League Against Epilepsy Task Force on Terminology, they would like to revise the definition of epilepsy to as follows. Number one, of course, at least two unprovoked seizures occurring more than 24 hours apart still satisfies the diagnosis of epilepsy. However, based on the new definition, even if you have one unprovoked seizure, if the probability of having further seizure is similar to the general recurrence risk, which is at least 60% after two unprovoked seizures, that means you already satisfy the diagnosis of epilepsy. What are the examples of this? For example, a child with developmental delay who had his first unprovoked seizure and his brain MRI showed perinatal stroke, or presence of, like, for example, lissencephaly. Therefore, the chance of having a second episode is higher. In that condition, probably this child may satisfy the diagnosis of epilepsy. And the third part of the definition is a diagnosis of an epilepsy syndrome. For example, a child with Rolandic epilepsy. For example, a child who had first or new onset seizure from sleep, whose features is typical of the Rolandic epilepsy, and you see on the EEG that there is this typical Rolandic spikes that we see in BRE, then that will already satisfy the diagnosis.
Okay. And so presumably it just means you can get a quicker diagnosis in some cases and start treatment sooner than you would have otherwise.
Yeah, this will help you, and help the physicians, the neurologists to consider treatment and help the family decide to whether they will opt for treatment or not.
Mm-hmm. Okay. So how should parents decide what type of physician should manage the treatment of their child's epilepsy? You could have a pediatric epileptologist, or you could have just a pediatric neurologist who happens to work at a comprehensive epilepsy center and therefore has access to all that that offers, or you could have a pediatric neurologist who's not affiliated with an epilepsy center, or even a pediatrician could manage it. What are the different circumstances that would dictate who you should see?
If the child has new onset unprovoked seizure, I recommend that a pediatric neurologist see the patient. However, if the child has intractable epilepsy, which means seizure that is difficult to control, it will be better to have a pediatric epileptologist who works in a comprehensive epilepsy center to evaluate the child. Because, if the child has already failed 2 seizure medication, we have to explore other possibilities of treatment options like surgery. Pediatrician can always evaluate a child after a first unprovoked seizure, but typically we would like the pediatrician to refer the child to a neurologist. The pediatrician may probably try to rule out any provoking factors like any electrolyte imbalance or any fever-related seizures in those who may have several seizures. But still, since we're talking about unprovoked seizures, pediatric neurologists should be the one to evaluate these children.
Okay. And what about someone who has well-controlled seizures? Maybe they've had it for a while and they don't foresee being, like, for instance, with juvenile myoclonic epilepsy, they probably will have to be on medication for a long time, even if their seizures are well-controlled. Would that person, if they had a choice between a pediatric neurologist and pediatric epileptologist, would it essentially be up to them, or would guidelines suggest that they see the lower level of care, I guess?
For you cited JME. JME is a type of epilepsy syndrome that can easily be controlled. So a pediatric neurologist who's confident, in taking care of these children. They are already teenagers, so this neurologist should also know how to counsel these families or these patients about the effect of anti-epileptic medication in women of childbearing age, teenagers. Ideally, of course, epileptologists, but sometimes there is scarcity of pediatric epileptologists. An experienced pediatric neurologist who is confident and extensive experience probably in treating children with epilepsy is sufficient if the seizure is controlled.
Okay, great. So when initiating treatment, what are the key factors that influence your choice of anti-seizure medication? And to what extent should physicians explain their rationale to patients and families when they're selecting such a medication?
So in my practice, the key factors that influence my choice of anti-epileptic medications are its efficacy on the child's seizure as well as its tolerability. So our goal is no seizure. At the same time, the child tolerates it. Every time the patients arrive in the clinic visit, physician should always on the first visit, physician should counsel the family why the child needs to be treated and what are the consequences of not treating. And during follow-up visit, the physician should also counsel the family about the side effects that can be seen with the medication. On the other hand, parents should always, if they have any concerns about the side effects of the medication, they should always let their physicians know about this.
Okay, and for most types of epilepsy, with a few exceptions, there may be numerous medications that would be appropriate choices. So when you select one, how do you explain that to parents, and do parents ever have a choice in that, in terms of that first medication that's selected, or the second medication if that first one doesn't work? I mean, how much do you explain, like, why you're choosing one over the other? Because there may be cases where several medications would be appropriate.
My choice of anti-epileptic medication, I always individualize these. Yeah. So whenever I see a patient, I discuss with the family what are the, like, for example, a child with focal onset seizure. I will discuss to them the medications that have been used for this and which medications have been known to be well tolerated by children, at the same time efficacious. And I also tell them the side effects of each of these medications. Of course, before I also investigate what are the comorbidities of the child, if the child has any underlying behavioral problems, or if the child is obese or underweight. I also take that into consideration. Right. If the child also has migraine headaches, there are seizure medications that they are useful not only for seizures but also for migraine. So all of this combination of factors help me determine which is the better medication for the child. So after discussing to the families the medications that have been used for this type of seizure together with their side effects, at the end I would tell them this is my recommendation. And most oftentimes families understand why I choose this medication. Some of them would like to do more research. Some of them would just follow my recommendation.
Okay. And has there been recently more research done in children in terms of clinical trials of a medication? Because I know probably earlier, most of the trials were done in adults, and then the information was applied to children.
Right.
Is there better evidence now of specific effects on children?
Yeah, there have been, now we have several new anti-epileptic medications that have been that have arrived, and one of which is clobazam, which is specifically used for children with Lennox-Gastaut syndrome, and there have been evidence that it is effective for this type of seizure. So the research has improved, and specifically for those children with intractable epilepsy. So there have been medications that have been tested on these children.
Okay, good to know. So what are the main reasons for discontinuing a medication? With the exception of, with the exception of severe or life-threatening side effects, how long should a typical medication trial be done to ensure that the side effects aren't just temporary?
What I typically do is, of course, when you start medication, you start it slowly. And, the goal is start slowly and escalate slowly. And typically we try to reach only the minimum amount of dose that will help prevent the seizures. You asked the question, when do you stop the medication? Is that right? Did I understand your question right? Allergic reaction. If there is a severe allergic reaction like Stevens-Johnson syndrome, of course we have to stop the medication. Or if there are significant side effects that is affecting significantly the child's quality of life, like, for example, severe mood changes, we would, which may happen from other seizure medication, we would recommend, again, we cannot suddenly stop, but we will wean the medication quickly, and then introduce a different seizure medication to prevent the child from having seizures.
Okay. And typically, how long do you give it? Before you,
right?
Because some side effects can be temporary, or they can adapt to them. So
usually, I give them few weeks, and if the side effects are still present despite, I try to lower the dose, then that's the time that I consider switching the medication.
Okay. And can you explain the difference between dose-related side effects and medication-related side effects, and how these different types of side effects are addressed?
Dose-related side effects are basically one of the most common side effects that we can encounter from anti-epileptic medications. When you say dose-related, it is related to the high or increasing concentration of the seizure medication in the child's blood. And the most common examples are sleepiness and GI or gastrointestinal side effects. It typically affects the quality of life of the child, but usually they can be reversed if you adjust the dose. When you say medication-related side effects, these are side effects that are specifically related to the actual medication. For example, if you develop a severe hypersensitivity reaction like Stevens-Johnson syndrome to dilantin, or medications like Depakote may cause, or valproic acid may cause hair loss. So that is the difference between the two. And how to address this? With the dose-related side effects, we just adjust the medication. And in my experience, most often times, if you lower the dose, or at least spread out the dose, most of these dose-related side effects is related to high amount of dose that is given every time the medication is given. So if you spread it out, depending upon the half-life of the medication, that sometimes helps with the dose-related side effects. When it comes to the medication-related side effects, again, we analyze the profile of the patient, and we try to avoid those medications that may cause these medication-related side effects. Like if the child is already overweight, then I will avoid trying this child on valproic acid.
Right.
Or if the child is already anorexic, not eating, I will avoid putting this child on medication that can cause him to further lose weight.
Right. And in terms of the dose-related side effects, do extended-release versions of medications sometimes help with that? Is that something you ever...
Yeah. Sometimes extended-release levetiracetam, for example, it is known to cause mood changes, and it has been said, based on previous studies, that the extended release lessen the fluctuation of the blood level of the medication in the system and may lessen the mood changes. So that's a good comment. And also, if there is a problem with compliance, also we use the extended release medication.
Right. It's fewer pills to have to take.
Yes, because especially for teenagers, who sometimes forget to take their morning dose, and I think the extended release typically helps with them.
Okay, great. And to what extent do a child's EEG findings determine whether or not a treatment regimen is successful? Is the goal no seizures, no side effects, or is the goal no seizures and no EEG abnormalities?
The goal is no seizure, no side effects. There are only rare epilepsy syndromes wherein we would like to, treat the EEG, and one of which is childhood absence epilepsy, wherein you see the typical 3-per-second spike in wave activities, and this type of seizure is very brief, and most oftentimes family members may not even recognize it, since they are very short. But if it is happening on a very frequent basis, that can affect the child's learning. And the other condition is Landau-Kleffner syndrome, which is otherwise called as the acquired epileptic aphasia, wherein 25% of affected children do not have seizures, but they develop language regression, They could not understand. They developed this what you call verbal auditory agnosia. And even if they are not having seizures, we tend to treat the EEG abnormalities because it has been known that treating the epileptiform discharges may improve the language or reverse the language regression in these children.
Okay. So if a child is seizure-free, is it ever justified for a parent to request additional EEG monitoring, like video EEG monitoring, if they haven't had it? Maybe they just want to know what the risk of a breakthrough seizure is, or figure out, is the child truly seizure-free? Maybe they're missing certain seizures, or maybe to determine what type of epilepsy the child has. Is that something that a parent can reasonably request, or is it based? Does it matter, or does it depend on whether their insurance will pay for it? It's just a kind of a complex.
Well, there are situations that we can do additional EEG even if the child is seizure-free. For example, a child who hasn't had any seizures, but parents have noticed regression in the development, like not learning in school. We want to make sure that the child is not having subclinical seizures. The other reason why we need to do this is, for example, a child who used to have convulsive seizure hasn't had any more convulsive seizure, but parents are concerned about new type of spells, like, for example, jerking at night or some episodes of staring. It is reasonable to obtain a 24-hour video EEG or a follow-up EEG, and especially if we want to capture a spell that we are concerned whether they are still seizures or not.
Okay.
And again, if the child is seizure-free, typically after 1 or 2 years of seizure freedom, we like to do an EEG, a follow-up EEG, to help us decide whether the child can be safely weaned from the medication.
Okay. And since we are talking about that, we'll skip ahead to one question, which is when do you start to consider weaning a child off medication, and what types of factors influence that decision? Obviously, you mentioned the EEG is one. What else would play into that decision?
Yeah, I mean, if the child, of course, is seizure-free, like have been seizure-free for 1 to 2 years. What else? If the child who has a epilepsy syndrome that should have been outgrown by puberty, and the child is already reaching puberty. Mm-hmm. Those are the situations that I consider weaning medication.
Okay.
Again, guided by the follow-up EEG.
Right. So at what point do you typically encourage patients and families to consider treatment options other than medication?
Well, I always encourage them to think about non-medication type of treatment if the child has intractable epilepsy, which means seizures that are not controlled by appropriate seizure medication, at least 2 or more. And in these situations, I always figure out whether the child can be a candidate for epilepsy surgery, and even if they are not, I always consider whether they can benefit from other modalities like use of vagal nerve stimulator or ketogenic diet.
Okay, so deciding which of those options to try can be a really complex process. Do you have any kind of simplified decision aid that you use with families to help them navigate that process?
Mm-hmm. Well, first and foremost, what I typically do is I order for a video EEG, which is the overnight recording, and I try to capture the seizures. And if I found out that the seizure is always consistently coming from one side of the brain, epilepsy surgery can be an option, provided that this will not cause significant side effects on the child. Children's Hospital of Michigan, what we typically do is for intractable or difficult to control seizures, aside from the video EEG, of course we do an MRI, which is on a 3 Tesla magnet machine, and we also do a positron emission tomography scan and neuropsychological evaluation. So these testings, we combine these 4 tests, and we discuss the case in our epilepsy surgery conference. And then we have a group of epileptologists and neurosurgeons, psychologists, neuropsychologists, who will discuss the patient's case, including the EEG, the history, EEG, MRI, and everything, and determine whether the child can be a good surgical candidate. If there's a if there's a focus, and the focus, once you remove it, it will not cause any significant side effects on the child. We typically recommend resective surgery, and we explain to the family the chance of being seizure-free with this procedure. On the other hand, if the testing shows that the child has several seizure focus, that means coming from the left as well as from the right side, we also discuss whether the child can be a candidate for other treatment modalities like vagal nerve stimulation placement or procedures like corpus callosotomy. And we also think about whether this child would benefit from a special diet called ketogenic diet.
Okay.
And again, this depends upon the seizure type.
Sure. So seizure control is typically the primary goal of treatment. So, but there are a number of secondary goals that might be considered, things like cognitive function, behavior, mental health, physical health, and just overall quality of life. How do these secondary goals influence your treatment decisions?
Yeah, if the child has intractable epilepsy, I mean, and already on several seizure medications, this is kind of hard to achieve these secondary goals. I mean, I try to lessen the number of medications that they are on, and try to control those life-threatening type of seizures, like convulsive seizures. In those children who has normal development and capable of undergoing neuropsychological testing, I also have them undergo neuropsychological evaluation and see what is the effect of the seizures and the seizure medications on their learning and their behavior, and see whether we can do any adjustment for this.
Okay. So under what circumstances do you provide parents with rescue medications or as-needed medications? And what are the advantages and disadvantages of the available options that are out there, like Diastat or intranasal midazolam and things like that?
Yeah, so children may experience what we call prolonged acute convulsive seizure, and the acronym for this is PCS, which means seizures that last for more than 3 minutes. Most likely this type of seizure, we always tell the families that if the seizure lasts for more than 3 minutes, less likely that it will stop on its own, and it may lead to status epilepticus. In such situation, we recommend rescue or emergency medications, and the usual medication that we use are the group of medication that comes from the benzodiazepine family. And you mentioned about rectal diazepam or Diastat. Currently, it is the only approved FDA-approved medication for rescue medication for seizures, but there are several studies and publications about the use of other medication types like midazolam, or what we call Versed, which can also be given intranasally, that means through the nose, or through the buccal mucosa. We put the medication in between the cheek and the teeth. We have also used clonazepam. It comes as an oral disintegrating tablet that will dissolve in the patient's mouth. So you asked about what is the advantage and disadvantage. All of this medication can acutely abort the seizure, but as I mentioned earlier, rectal diazepam is the only formulation that is approved by the FDA. Although now there have been some research or publications suggesting that intramuscular diazepam is also effective. When it comes to older children, the oral ODT formulation or oral disintegrating tablet formulation of clonazepam seem to be more practical compared to rectal medication and more socially acceptable. So that is the type of rescue medication that we use for older children.
Can that be used in the case of tonic-clonic seizures? If the person's not fully...
if that, you can use it, but you have to put it in between the buccal mucosa and the teeth so that the child will not aspirate. So it is supposed to dissolve rapidly. But the more ideal scenario is to use the intranasal Versed too, because it doesn't have to go through the mouth. And we usually use an atomizer, which is a device that will convert this liquid medication into a mist. So therefore, it will rapidly absorbed by the body.
Okay. And you mentioned intramuscular, which I assume presumably is like a EpiPen sort of delivery system.
Something like that. They call it auto-inject.
Currently, I know it's not FDA approved, but is there a way that...
Not yet FDA approved, but there have been research using this in Vanderbilt, and they found it to be very useful. Actually, they have used it even, if they're for adults who have, they still have clothing, and they can inject the medication directly into the clothing, which I found interesting.
Okay. Can parents actually get this somewhere or no?
I'm not sure whether it is currently available in Michigan, but in Vanderbilt they have used it in many of their patients who are admitted in the epilepsy monitoring unit.
Okay. All right. So tracking seizures and side effects can be challenging for parents, particularly the child's ability to communicate is limited, either due to their age, if they're too young to communicate, or due to a disability that affects communication. So, for example, children may not be able to accurately describe a simple partial seizure that is internally experienced. They may also have a hard time describing side effects with any level of detail beyond simply saying, I feel yucky or something like that. So, if a parent is constantly worried or hypervigilant about watching for seizures or side effects, that can have a negative impact on the child. So, given the challenges of, tracking seizures and side effects, and how do parents accurately do that without hovering or causing unnecessary anxiety?
Yeah. This is a very difficult question,
right.
because as a parent, you cannot avoid not to be anxious about seizures at the same time anxious about the side effects of the medication. I think keeping us, the neurologists aware about their concerns will help allay their anxiety. If there are questions about seizures, whether the child is having a different type of seizures, there are several apps that are available right now, like the seizure tracking app, wherein parents can take videos of the episode. So when they see their neurologist on the visit, they can show it to them. Actually, it's very useful. I have recommended that to most of my patients. With regard to the side effects, many of the side effects that they may encounter in their children are not life-threatening, but may cause problems with the quality of life. So mere adjustment in the dose may help with this, like what I mentioned, like lowering, spreading out the dose of the medication may help lessen these side effects, like if you give oxcarbazepine on 2 times a day dose, spreading out, because with the 2 times a day dose, the child becomes so sedated, you may spread out the dose. So, I cannot blame the parents from being anxious about the side effects and at the same time about the new seizure types. So probably keeping them well informed about the child's epilepsy will help allay this anxiety.
Right, and also help them to know what's a seizure and what isn't, and yeah. Yes,
what is a seizure and what isn't. And typically, to my patients, I give them my email address, and those parents who are concerned about certain behavior that they are not sure, they usually upload it to their email, and I analyze the video, and I tell them whether do I think this is a seizure or not. So, and usually that helps them,
Okay.
Because many of these episodes, when they see their neurologist, it's hard to describe without showing the video. So I recommend to families to try to use their iPhone. It's very useful because it will really show what they are concerned about. And I think most family members have learned how to do this,
Okay. And what about nocturnal seizures? That can also be a huge source of worry for parents, because they're concerned that they might miss a seizure for tracking purposes, and also because they're concerned for the child's safety. So when should parents when should they consider sleeping in the same room with their child, or using some sort of monitor or seizure detection device?
Well, I agree with you. Nocturnal seizure is one of those anxiety-provoking type of seizure because, it happens, as the term implies, nocturnal. They only happen at night, and usually these seizures are related to seizure activity coming from the frontal lobe. Mm-hmm. In my practice, for patients who are having multiple episodes and those who tend to have convulsive seizures, I typically want the family to at least check the child. It can be hard, but that's one way, especially if the seizure is uncontrolled. I usually recommend them to at least, look at the child when they wake up to go to the bathroom, or it's better to sleep with the child, especially if the seizures are happening several times in a night. And I am usually guided if I do a video EEG at the hospital and I determine that the child is having nocturnal seizures that parents do not recognize. I counsel them that these episodes are happening, so I will ask them to keep an eye on it. Nowadays, there have been several devices that have been used to monitor, or at least to help track seizures. There are devices that can track movements by putting it in the mattress, and there are also devices that we use like a bracelet. Again, these devices have not been FDA approved to track seizures, and they are useful for those seizures associated with movements like convulsive seizures. If the child has partial seizures, like those seizures that is only characterized by staring, these devices may not be able to track it. There have also been devices like camera or monitor that can see the behavior of the child while they are asleep. And again, like what I've said earlier, these are not FDA approved, and most of the evidence comes from studies performed in the epilepsy monitoring units in the hospital, and we don't know yet whether this is really helpful.
Right. Okay. One thing I forgot to ask when we talked about weaning off medication, what does the research show in terms of the likelihood of having a seizure after weaning off medication? Is there a general percentage, or is it different for each type of epilepsy, or different base? Do you provide a customized risk, I guess, for families? Or
the risk of relapse after being weaned from the medication is kind of broad, range from 11 to 85%, depending upon the presence of identifiable risk factors. Sure. Studies have shown that if the cause of the seizure is idiopathic or genetic, if the child has normal exam, normal development, if the child has Rolandic epilepsy, if the child had a good response to the first anti-epileptic medication, usually the success rate of being able not to have another seizure after being weaned off is high compared to those children who has abnormal MRIs. That means they have secondary causes of epilepsy. Those with mental retardation, abnormal exam, we know that JME or juvenile myoclonic epilepsy, they are treatable. It's easy to control their seizure, but their disorder is kind of lifelong. the other factor is for initial response to the seizure medication. They tend to have higher rates of getting or having a relapse after being weaned off. And, of course, EEG abnormalities. So that's why we always do an EEG before we consider weaning the child from seizure medication.
Okay. And before we open it up to questions, do you have any closing thoughts on this topic or any messages you'd like to share with everyone?
Well, I just want to let the families know that the research has improved, and there are several things that we can do for children with epilepsy. And we physicians always try our best to allay the anxiety of the families or the parents of these children with epilepsy. And we are here for them, and I mean, they should always ask their neurologists of any concerns about their children's epilepsy, and if the child has intractable epilepsy, I recommend that they should be seen by a pediatric epileptologist, and preferably in a epilepsy surgery center, because there are seizures or epilepsies that can be treated by surgical options.
Okay, great. Well, let's open it up for questions. I just have to dial something here, and I'll be off for just a second, and then it will everyone will be unmuted. So just a second here. Okay, who'd like to get us started off with questions?
I have a question.
Okay, go ahead.
I've done a little reading that suggests medication typically doesn't help absent seizures, and I'm wondering if that is correct or not. And if not, what medication you tend to recommend for absent seizures, and what kind of success do you have, what medications those would be, and what the percentages would be of how patients respond positively, whether can you eliminate the absent seizures or you just reduce them?
Absent seizures, these are what we call also petit mal seizures, and there are two varieties. We have the childhood absence and the juvenile absence epilepsy. When you say childhood, it happens during childhood. Juvenile absence, it happens during later part of the childhood, like 10 years old until around teenage period. The childhood absence epilepsy, they are the ones which are that can be outgrown, and it's not true that there are no seizure medications that will not help with absence epilepsy. Actually, a few years ago, there was a randomized trial or a trial comparing 3 seizure medications that are useful for absence epilepsy, and in that paper, it was found out that Tonicclonic and valproic acid, these are the 2 medications that help with this type of seizure.
I'm sorry, could you say those meds again?
Tonicclonic. The brand name is Zorontin, and the other one is valproic acid, and the brand name is Depakote. The third medication that have been used is Lamictal or lamotrigine. So it's not true that seizure medications are not helping with these seizures, especially if the seizure is only purely absent seizure. Most of them outgrow their seizure. I mean, of course, with the help of the medication, and usually they outgrow by the time they puberty.
My daughter, which was just diagnosed last week, and she took the EEG in the Children's Hospital. Mm-hmm. And I want to know if when the doctors see the results, do they consult with another doctor, or is that valid to look for a second opinion of how this works?
Did they tell you whether the EEG was abnormal or normal?
My doctor just called me later by the phone. And he told me my daughter has a lot of seizures. And he told me he just needs to put her on medicine right away. Mm-hmm. And I didn't have the chance. I don't know if, many of the doctors check, the results.
Yeah, for the EEG, I am one of those EEG doctors who read EEGs, so it depends upon who read the EEGs. We analyze and we interpret the EEG, and if we see abnormalities, we read it as an abnormal EEG, suggesting a tendency to have seizures. So probably in your child's case, her EEG turned out to be abnormal. How many seizures did she have?
I don't know, but they said that there were many.
There were many seizures. Among the seizures that you have seen, how many seizures have you seen at home?
Well, that's kind of the absent seizures. Like we just saw the blinking. Yeah, she was the only thing we can see. She was blinking, right?
Mm-hmm. How old is your child, Mom?
She's 11.
11 years old, and she was just diagnosed to have absent seizure. Is that correct?
Yes.
No, that's like
the EEG can show absent seizures because there is a maneuver that we do, or activation procedure that we do during EEG. We call it hyperventilation. If you remember, when your child had an EEG, he or she has been asked to blow a pinwheel. So I suspect that during the EEG, and when she was asked to hyperventilate, they were able to record seizure activities, because this is the type of seizure that can be triggered by blowing pinwheels or doing hyperventilation. You mentioned about second opinion. You are always welcome to ask for a second opinion. Since this is your child, you can always call our hospital and ask whether your child can be seen by another neurologist, and so that you would be more clarified with a diagnosis. What medication did your neurologist recommend you to give to your child?
Epilepsy. With lab, I don't remember. I'm in my car now. And the truth is that I don't remember the name, but I think somebody mentioned it. Lamictal or
Is it lamotrigine?
Yeah, I think so.
Lamictal.
Yes.
I see.
That one.
So, this is one of the seizure medications that we use for absence epilepsy. Remember I mentioned about ethosuximide, valproic acid, and lamotrigine. Your child is a female or a male?
It's a female.
Female.
Yeah,
that could be the reason why if you would like to get a second opinion, you are welcome to do so.
Okay, but already 2 or more doctors, so that, for giving the diagnosis, it's just not a doctor who saw the results.
Can you say that again, ma'am?
I said, before they give the diagnosis, 2 or more doctors already in Children's Hospital check the results.
Yeah, before they tell you that this is the diagnosis, of course, your neurologists have already collected the evidence that this child has this diagnosis. So the neurologists typically combine the history as well as the EEG findings or the results of the test. Aside from the absent seizure or the eye blinking seizure, does she have other seizure types like convulsive seizures?
No.
No, I see.
No.
If you have any concerns whether your child really needs to be on seizure medication, I usually encourage my patients to get a second opinion if they want to.
Oh, okay. Thank you.
Other questions?
Welcome.
I have a question.
Go ahead.
My question, first of all, I want to say your lecture was excellent. You covered so much in a short amount of time. I really appreciate it.
Thank you.
If my daughter has simple partial seizures that are sensory seizures, And I'm wondering, how often would you recommend like a neuropsychological testing in a situation like that, knowing that hers are refractory? She has them almost every day. And I'm just wondering, you know, if neuropsychological testing should be done every couple years or...
Well, for children with intractable epilepsy, and even for those children who has controlled epilepsy, but having some learning issues at school or memory problems, I typically recommend neuropsychological evaluation. And in Children's Hospital, it is Dr. Rothermel who does it. And Dr. Rothermel will evaluate the functions of each areas of the brain, and he would make recommendations if it is necessary, how to help the child to adjust in school, to compensate for these difficulties. Sometimes he would recommend a follow-up neuropsychological evaluation after a year. So you mentioned that your child has intractable epilepsy, is that correct?
Yes.
Okay, and do we know where the seizure is coming from?
Yeah, she had a resection at Children's Hospital. It just wasn't, it was near an eloquent area, and they probably were not able to just resect the entire epileptogenic area, so she still has these sensory seizures.
But probably the big seizures have been controlled, is that correct? Like, sensory means just one side of the body is feeling some focal seizures, is that correct?
Correct. I mean, she only had one, unprovoked tonic-clonic, seizure, and then they started her on medication, and then we did the whole thing like you described. MRI, saw the focus, did the PET, worked her up for surgery. So she's never really, her typical seizures were not, generalized tonic-clonic seizures. But yeah, she's not had one since then. Okay, then she benefited from the surgery. And neuropsychologically, is she improving in her learning, or is she acquiring skills? It's not. It's kind of hard to say. She's definitely not, a significant decline. I just wondered if that's something where there could be some subtle deterioration going on that you wouldn't recognize unless you did neuropsychological testing, periodically. Yeah. When was the last time she had a neuropsych testing? Just post-surgery, like 3 years ago. Years ago. And have you noticed a change from the last time, from prior to surgery? Have you noticed any concerning? Probably not significant, no. And is she still on seizure medication, right? Oh, yes. Uh-huh. How many seizure medications is she on? She's on 2. 2 seizure medications. Yeah, if there's a concern about any deterioration in her learning, I think neuropsychological testing will be helpful, not because we are doing another surgery, but because just to figure out how can we help her. Because, the purpose of epilepsy surgery is not only to make the child have less seizure, but also to improve the quality of life. Right. If you have noticed any deterioration in learning, memory, then I think it is justifiable to do another neuropsychological evaluation just to see. Because with the neuropsych testing, the neuropsychologist will be able to figure out whether these learning issues or memory problems are related to the medication she's on or due to the underlying epileptic disorder. Right. Thank you very much. You're welcome.
Okay. I think we had one other person had started to talk at the same time. Did someone else have a question?
Yeah, that was probably me. Hi, this is Dawn. Okay. My question, this conference call has been just jam-packed with information. I'm very happy to have participated. I have a quick question. My son is 6. He has been seizure-free for 2 years. Mm-hmm. He's taking 2 medications, Keppra and Trileptal. He has had fabulous results from them, no side effects. He's been doing very well. His seizures were complex partial seizures stemming from the occipital region of his brain. And my question is,
how do I know if he's just a regular 6-year-old boy in first grade who doesn't always want to pay attention to what's going on, or if this is something I can assume is maybe stemming from the medications that he's been on half of his life?
I see. When was the last time you saw him having seizures, Mom?
It's been, it was 2 years ago in November.
2 years ago. So it's been 2 years. I mean, as I mentioned earlier, neuropsychological evaluation will help because, you know, there are findings on the neuropsych testing. When the neuropsychologist saw that they can see a pattern that this could be related to the medication or maybe related to the underlying epilepsy. Do we know where in the occipital lobe, whether left or right side, where the seizure is coming from?
I don't know the side. I think it was left, but I'm not quite sure.
Right. I see. I think it would be good to have a neuropsychological evaluation.
Okay, you know, we see Dr. Fatima Siraji. We love her. She had mentioned it before that we have him do that when he was in kindergarten. But my thing was, you know, he's bilingual. He's reading at a third grade level. He's, you know, doing so well. I just didn't think that maybe there would be anything that needed to be tested, but now that he's in first grade and he's having a hard time focusing and paying attention, that maybe it's something we should look into.
Yeah, I would I'd explore that, you know. I mean, it is common among children with underlying epilepsy to also have comorbidities, like learning issues, behavioral problems. Do we know what is the cause of your child's seizure?
No, there's no cause, no reason.
MRI is normal?
Yes.
I see. Yeah, I think it will give us more idea if we do the neuropsych testing.
Okay. Thank you. Thank you very much.
Yeah, you're very welcome.
We did have a Learn and Share conference call last year on attention and executive function in epilepsy, so if there's issues of focus, that would be something you could listen to that Learn and Share call on our website, and if you didn't participate in it, and that way you could find.
I'll look that up. Thanks, Russ.
Yeah.
Thank you, Russ.
We're a little past our end time, but did anyone have one last quick question? Okay. Well, thank you everyone for participating. And thank you so much, Dr. Luat, for your time. And I'm, again, glad you made it home safely tonight to be here with us. And we really appreciate it. And I think everyone learned a lot new tonight.
Thank you very much.
Thank you.
For all parents who or at least listen to my talk, and it was a pleasure.
Great. Thanks again, everyone.
Mm-hmm.